Hey guys, good morning. I think we're still waiting on a few more, and I can't actually turn the doorbell chime off when people come into the classroom, so I'll just give them another minute-ish, just so we don't have that being interrupting. Oh no, I can turn it off. She made me an alternative post. Okay, all right, I think we should be good. So I'm gonna try something a little bit different today. I did just like screen mirroring with my iPad so that I could like circle things as we're talking about them. And I think that will be a little bit more helpful because we're doing a lot of just CBCs today. So we'll try it out. And if it's a big pain and it's caught, like if your screen is lagging or anything like that, we will abandon ship and just go back to the PowerPoint. But I thought we might try it out at least. So we have anemia part one today. Part two is your macrocytic and your normocytic anemia. So today is mainly just microcytic, a lot about iron deficiency, thalassemia, some sickle cell too. Um, your most common type of anemia is iron deficiency. So that's the one you're going to see really, really often. And these anemia lectures are broken down per that morphologic approach. Remember, that's per the MCV. What's the size of these cells? But an important caveat to that is that you have to understand that an MCV is the average. So if you have a population of really small cells, like an iron deficiency, microcytic, but you also have a population of large cells. So large and small, that's going to average out. So you might actually have normal size red blood cells if there's a mixed picture. Now, when you're taking your exams, like the exam that I wrote for you, the PANCE, the PACRAT, they use like purely one etiology, just microcytic and iron deficiency, macrocytic and B12 deficiency. It won't be like this big mixed picture. But when we like talk about these within our class discussion, sometimes I present some of those harder cases. And next semester, when we do nephrology, we'll talk about that as well. We'll introduce some more anemia topics because patients with chronic kidney disease, which we discuss in nephrology, often have anemia. So let's go ahead and get started. Let me just move some stuff around on my screen. Is this big enough on your screen?
Yep.
Yeah, okay, cool. Okay. All right. So these are the CBCs that were at the end of the class discussion for last week. And I mentioned to you that I wasn't going to go over them that day. We would just talk about them today because a lot of them are just anemia CBCs. This is the one that we ended on. If you look at the top where the purple is, you have your white blood cells and then your granulocytes being low. If you recall, I kind of complained about our in-house CBC machine because it doesn't differentiate the granulocytes. So here I know there's a leukopenia, low white blood cells, but I don't know which granulocyte count is driving it. Now, the most common granulocyte, as you know, is a neutrophil. So most likely this is a neutropenia. But a neutropenia it's important to differentiate. So it's not as big of a deal when it's low because it's almost always neutrophils being low. But when it's high, it's even more critical. And just allow me to pause for 1 second. I just have to close my window curtain just so that my dog doesn't see stuff that's happening around. All right. So white blood cells, we'll focus more on that within part two of hematology, which is the malignant heme section, but we'll talk a lot about non-malignant white blood cell deviations as well. So back to the focus of today, anemia. We have red blood cells are low, hemoglobin is like right on, and then hematocrit is low. So we have an anemia, then we characterize it first by the MCV. So this one is macrocytic. And with your macrocytic anemia, sometimes you'll see the MCH has gone up, but it doesn't necessarily represent like too much hemoglobin content, it's often just because those cells are larger, they have more hemoglobin content. It's not like disproportionate hemoglobin content or concentration. So you often see a little MCH bump when you have those larger cells depicted by the MCV. Now, this one, there was a typo that someone had mentioned to me last time. I had typed that the RDW was high, but here it's actually low. And I know I talked about that, but I just wanted to point it out here again, too, because on the next slide, I had corrected that. So this is just the key. We'll talk more about those white blood cell abnormalities in the future. So we'll go to the next one. Here we just have red blood cells are down, hemoglobin, hematocrit, but the MCV is normal, the MCH is normal. So if you had to give this CBC a diagnosis, like if you had to describe it, how would you do so? We'll just use the highlighter. I think that's better. Chris, you got it. Normocytic, normochromic. And that is like that's part of our differential for next week. But it's important to just, work with those classifications. So there's our answer. And it's important, like I always like I type it out here because when I am interpreting a CBC, that's how I go about it, very systematically. And if you're systematic every single time you interpret a CBC, you're going to make sure that you don't miss things. So here we have red blood cells are high, hemoglobin is on the high end, but it's not yet technically high, and hematocrit is high. So what would we call this? This will be the opposite of anemia. Rachel, Paul, you got it. So polycythemia or erythrocytosis. Polycythemia is certainly the term used more often, but I just want to make sure I throw out both of them. Good. So there's the key for you. And then this one, white blood cells are high, granulocytes are high. Same question, which granulocytes? Is it neutrophilia? Is it eosinophilia? Is it basophilia? Which granulocytes? So this is helpful. Like I mentioned, the only times I really used our in-house one because it didn't differentiate granulocytes would be like if I had an acute mono case, because you have a patient who comes in and they have a sore throat and they feel like crap. Well, that could be like a lot of viral illnesses. And then you look in their throat and they have exudative pharyngitis. They have pus in the back of their throat. Strep test is negative, but that's only group A strep, and group B strep and group C strep and all of those, they can cause pus on the throat too. And you do a monospot test. And monospot and mono is something we'll talk about more in part two, but that could be negative. And it could be negative just because you're early in the course of the disease, but you really think it's mono. So if you get a CBC, you'll see that they have a leukocytosis and often a lymphocytosis. So that could be really helpful for treatment decision making, like in the moment. But yeah, you're correct in the chat there that this is most likely a neutrophilia. But I was just pointing out like those are like the limited times I would actually use this test. And your in-house CBC machine, wherever you work or you do rotations, may differentiate them. Good. Going to this one, this has an RDW that's low. So I mentioned before an RDW that's high, that means something. That means that there's an increased distribution width. We have small cells and large cells, and there's a big variance between our cells. An RDW that's low, especially just like a couple tenths off, that doesn't really have a clinical significance. So a question here in the chat is, would you have lymphocytosis with strep or other bacterial infections? No. So this, and I don't want to like table your question, but I'll just briefly talk about it because that is more of our part two. With strep, being that it's a bacterial infection and then other bacterial infections, usually you'll have a neutrophilia. Lymphocytes, they are going to predominate and they'd be higher with viral infections like mono or other types of viruses. So that pattern will be important. Neutrophils will be more bacteria driven, and viruses, you'll have lymphocytes. But we'll talk a lot more about that in part two as well. Good. So there's just the key. And then here we have a patient that red blood cells are okay, hemoglobin is okay, it's like borderline low, but our indices are off. So MCV is low, MCH is low, RDW is high. So we have a microcytic hypochromia without an anemia yet. But the RDW is high, which makes me think maybe something is brewing. So when you look at iron deficiency, which is our big topic of today, we have um, the first thing that changes is the iron actually goes down. The iron, the ferritin, the TIBC changes. And then you start to see the indice changes, like the cells become smaller and more pale. And then the last thing that happens is you actually become anemic. So if I get this across my desk, I'm going to tell the patient that your cells are a little bit smaller and more pale, and that often indicates that the iron is low. I'm going to ask questions that correspond to iron deficiency, heavy periods, bleeding, stuff like that. And then I would probably get this patient back in to check their iron and check their iron labs. So that's our key. And then I wanted to show you this CBC. I really hate these two when they like write them out and it's not like in perfect table format, like things aren't aligned because it's just like hard like to see it and like pick out what's abnormal. This one, everything happens to be abnormal, but sometimes, and you'll see I have some like heme consult notes. Sometimes they'll put the CBC values in straight up like paragraph form. And occasionally they'll like bold what's abnormal. But yeah, the way that it's presented can be varied, but most like on your pants pack rat and the didactic exam, the one I wrote, I use tables and everything's just like easy to like actually visualize. Yeah, another question here in the chat. This is a good one. Indicating pale RBCs would be the MCH or MCHC because that's the hemoglobin concentration. Smaller, bigger, that's MCV, paler, darker, that's MCH and MCHC. Good. So now moving on to just more and more CBCs. That's the reason why I really like this class is if you just like read the lecture first, the exam would be pretty hard for you if you just read the lecture because there's a lot of like lab interpretation, but it also wouldn't prepare you well enough like if you only did the lecture and then had to like go out and interpret CBC. So we have a lot of practice ones here. So this is the kind of the same story. You have a patient who has microcytosis, hypochromia, those are both down. RDW is increased. So same story as the last one. And let's just kind of tie that into a case. So we have a 56-year-old who comes in. She's coming in for a physical. She has no complaints. And red blood cells, hemoglobin, hematocrit, they're low. So there's anemia. MCV is low. There's microcytosis. MCH is low. Hypochromia. Iron indices. We're just being generic right now. They're decreased. So she has an iron deficiency anemia. What's on our differential for iron deficiency anemia? And DDX is differential if no one has used that abbreviation before. So what are you concerned about that could be causing iron deficiency? Bleeding somewhere? Thalassemia doesn't typically cause an iron deficiency, but it can cause a microcytic hypochromic anemia. Poor absorption. Yeah, those are, big ones. The most common cause is bleeding somewhere. So how would you proceed in a post-menopausal female? So if I came in and I have iron deficiency, I'm premenopausal, and so I'm having regular periods, you would want to kind of target like, are you having heavy periods? And if I said yes, you would want to evaluate and treat that, right? And then go down that side of the algorithm. But if I were postmenopausal or I'm a male of any age, so I'm not thinking about menstrual blood loss, you kind of go down the GI track. So you typically Like you can do some things like outside of procedures, like in primary care or even like at the bedside somewhere else, you can do stool testing for blood. But typically that patient is sent to GI to have scopes done, to do colonoscopy and then sometimes endoscopy as well. So if they are postmenopausal, female or a male, you go down the GI tract. So it was just a little irony deficiency about that one. And just showing you here like what some abnormal ones look like. So I don't have like the iron panel with this lab doesn't like group them all together. So you can see ferritin is separate from iron and TIBC. I'm just gonna change the color. Ooh, yeah, there you go. Um, but ferritin is low, iron is low, TIBC is okay, it's at the upper end. But this is a classic iron deficiency pattern. The RDW, got to remember that increased. So, two of our main topics today, iron deficiency, thalassemia. The RDW and iron deficiency is going to be increased because we have this mixed picture. Some of those microcytic cells from iron deficiency, maybe some of my old normal cells in that picture, right? Because red blood cells last for 3 to 4 months. And then we also might see some reticulocytes because the bone marrow is like, all right, I got your back. I'll spit some out. They're not ready. They might be a little big, but I'll give you what I got, right? And then that'll be that variance we see in the RDW. Whereas with thalassemia, RDW is going to be normal because those cells are genetically abnormal. They're coming off the line small. It's not like thalassemia, pops off one day because you had this, you had that. It's always going to be small. So the RDW is going to be normal in thalassemia. So that's one helpful differentiating factor. We'll talk about some other ones. Now, this cell is one that I really didn't talk about much for a few years. It was just kind of like thrown in there, but I started seeing it in like Pants Prep Pearls and on Rosh review questions and stuff like that. So I wanted to set it as a reminder. So does anyone recall these like elongated cells? They're not tapered at the end like sickle cells. Sickle cells are elongated and tapered. Yeah, these are your pencil cells. And then your sickles will be like more crescent shaped like that. It's kind of fun doing it this way. Yeah, so your pencil shaped cells, just be aware of that kind of buzzword. So here you have Sarah, who's a 35-year-old female. She comes in, she has brittle, concave shaped nails that appear spoon-like. So if you want to try typing out that term, you're welcome to. You could also unmute. It's kind of a funky term. Yeah. Iron low, you want to be thinking about that, sure. Like, since it's systemic, usually the cholinicia will affect multiple nails. And usually it affects the hands because the toenails grow a lot slower, but it'll affect multiple nails. If it were just like one nail and you saw this concavity, you might think about, some kind of like finger flicking or some kind of like external trauma. But this is cholinicia, the spoon-shaped nails. So here's just another picture of those spoon-shaped nails. And then you also, something you see with all of the nutritional deficiency anemias, iron deficiency, B12, and folate, you can see this like chapping at the oral commissures. What do you call that? Chris, you got it? And it doesn't like, it's not the most common finding, but it can be seen with any of them. So that's the angular cheilitis. Yeah, it does kind of look like the Joker. I never thought of that. Yeah. Same thing with people who have like lip lickers dermatitis, which my 3.5-year-old has had recently because he just has like constant runny nose. He's just like licking it. So he had that. And I thought about the Joker with him too. Okay. Yeah. So this is angular cheilitis, as you guys mentioned. So this is another one. I think GI is this semester for you guys. So you'll probably talk about this there as well. But when you have anemia and dysphagia, so you have a patient with iron deficiency anemia, they have trouble swallowing. What are you worried about there? What kind of goes with that picture? Yeah, they'll have those esophageal webs, and that's called Plummer-Vinson syndrome. Super high yield. Whenever there's a syndrome that connects like multiple body systems, pants, me, everyone loves to talk about it. So that's Plummer-Vinson. What about this symptom here where people crave non-nutritional substances? And this is something that, and this is pica, as everyone is guessing there. People often crave ice. So you'll see like pregnant women, it's very common to crave ice when they're iron deficient, but it happens to everyone. It's just iron deficiency is common in pregnancy. But when patients have like they get quick iron repletion, like they get IV iron, they'll often note like immediately after the transfusion of iron or even like in the middle, they'll say the craving went away. Like it's very, very sensitive to iron repletion. So I think that's kind of interesting. I've had three patients that I've done iron transfusions for say that like it went away in the middle. So when you give someone iron, whether you have them take it over the counter or it's a prescription, what's the side effect that you want to warn them about? Because if you don't warn them, they're going to experience it hard. They're going to stop taking it, and then, you're not helping. Yeah, it's a gut wrecker. It really is. Constipation, black stools, just stomach upset, nausea. So, um, I'm just reading. I'll finish what I'm saying. So you want to make sure that you warn them about that, and that's the reason why like and many people would like start iron kind of slow. So you might tell someone like I was like not really back in the day, but I don't know, 12 years ago during my didactic year, we were recommending people to take iron 3 times a day, every day. That's no longer the recommendation, but you can imagine like that was a belly bomber. Like that was not fun. So even then, a lot of people, when that was the recommendation, would tell people like start taking it once a day, and take it every other day and just kind of like build up. So yeah, it can be really difficult. So now the recommendation is that it's actually better absorbed or even like equally slash better absorbed when you take it every other day. So people tolerate it a lot better. So I just want to look, there's some comment in the chat about delivery here. We don't see the answer, so some students are answering. So there's something in the chat about we don't see the answers. You might,
Hi, Professor. Sorry, I just thought maybe if
yeah,
I um
that's fine.
no, so I just a few slides back, you mentioned the differential for the patient that came in with for routine physical and the chart that had all the decreased values.
Yeah.
So, do you mind repeating what the answer was for the most likely differential?
Oh, yeah, absolutely. So when you have a postmenopausal female who comes in and she has iron deficiency, your big differential there is going to be blood loss, like in the GI tract. And that's the same thing for males who are thinking blood loss in the GI tract. For premenopausal females, you're mainly thinking about menstrual blood loss. But those are just simplifications. If you go back to the actual PowerPoint, it has a slide on like iron deficiency common causes and it breaks them down too. And it shows like which ones are more common and that there are more. Like there are other things like with just low intake, like in their diet, malabsorption. There are other issues too.
Okay, thank you.
Of course. Yep. And then someone said I worked in primary care and rarely saw patients able to tolerate oral iron. Yeah, it depends. It really depends on like which one you use and like how quickly you ramp it up. I'll talk a little bit more about that in like one or two slides. Um, and iron infusions can be rough too. Um, yeah. So we do what we can to like modify diet. but sometimes that's not enough and people have to take iron and I'm pretty easy with it. Like, even if your iron is really low, like I'll say like, okay, do everything you can in your diet, but we've got to add in this iron. And that brings me to the next part about what kind of supplement you can take to increase the absorption of iron. It's not really about tolerability, but it's about increasing the effectiveness. Which one of these? Yeah, you can do just like a lot of them have vitamin C in them if they're over the counter. The prescription ones do not. So they can take vitamin C gummies with it. They can drink it with orange juice. They can eat it with an orange, whatever. That's fine. That helps with increasing the absorption, but not really tolerability. Some people have to change different formulations. Like you prescribe ferrous sulfate and that doesn't work, and you have to go to ferrous gluconate. So when you work in a setting where you might be treating this, you typically like find one that you're really comfortable with. Like I find people are a little bit easier with like ferrous gluconate. So I have like the SIG memorized for that, and that's the one I have in like a dot phrase, and it's easy for me to just send. But if that doesn't work, I go to a different type of pill, like the different salt, the gluconate, the sulfate, and so on. And if that doesn't work, we might try like a different route. So instead of a pill, they have like droppers, they have liquid. Sometimes that's better tolerated. But there are times people just cannot tolerate it oral at all, and that would be an indication for getting it intravenously. And then there are a bunch of different types of intravenous too. Um, some are more likely to cause allergic reactions, so they have to do like test doses, and sometimes they have to administer like Benadryl with them. Some of them are really slow, like can be like 6 to 8 hours of an infusion, and some of them are kind of quick. So there are a lot of different options for iron. I usually go start with like the cheapest one, the quickest one, and then kind of just play with it from there. But another thing that you can do is iron is best absorbed on an empty stomach, but that's hard. So sometimes I'll tell patients like, if you're going to eat it with something, like eat it with something really small, like a clementine, like one of those little cuties, an orange, a glass of orange juice, like something that's going to help it work anyway. Or again, like something small. Again, it's best absorbed on an empty stomach, but if you can't tolerate it, you're going to be better off if you're eating something small rather than like, taking your iron with like a huge meal. So we start with the ideal scenario, empty stomach, and then we work with them where they're at from there. So I'm a big Marvel fan, so I love this one too, but we'll just keep going. We have Polly with the pica. So you can see everything is decreased here. Hemoglobin, hematocrit, red blood cells. So we know there's an anemia. We have MCV is down, so microcytosis. MCH is down, hypochromia. We have platelets increased, and then our iron panel is classic for iron deficiency. Iron is down, ferritin is down, TIBC is up, classic pattern there. So when we look at some questions we have about this one in particular, a question I want to ask is, what do you think the RDW is going to be? So RDW is going to be high with iron deficiency. We talked about that a few times, so just a knowledge check there. And then you also want to pay attention to the fact that the platelets are elevated. This is unlikely a pathologic thrombocytosis. This is typically a reactive thrombocytosis. The patient is iron deficient, and the bone marrow's like, all right, I'll give you what I got. Here's some platelets. So it's often a little bit of a compensatory overproduction, but platelets, just like ESR, CRP, which you may not have been introduced to a lot this early in semester two, but those are acute phase reactants. Those are labs that just go up with inflammation. Platelets are also acute phase reactants. So this pattern is pretty standard. Here's another one, same kind of pattern there. Red blood cells, hemoglobin, hematocrit, MCV, MCH, all down. So I just wanted you to have a ton of CBCs on it. And this is that patient's iron panel. ferritin, iron saturation, all down. TIBC is up. So TIBC is the one that actually goes up. Everything else goes down. Because remember, TIBC is the capacity. How much space do I have for iron? If I'm iron deficient, I've got plenty of space. TIBC goes up. This is just another CBC that matches with the same story. So I won't bore you by reading it out again because it's the same exact pattern, but I wanted you again to have a ton of them. And same pattern here again. So you can peek through those. Here, just pointing out that sometimes the labs, it'll be so low that it says like it's too low. And that's usually marked by something like this. It's less than 3. It's so low, I can't really detect any lower than that. So that's interesting. You'll see that on lots of different labs. These are just some mind maps I found a few years ago for iron deficiency. So if you're someone who likes those, you can peek through them. If there's anything new in anything that's in the class discussion, like it's not game for the exam, it's just FYI. So now we move on to iron overload. Now, iron overload, this guy made, suit made of iron, needs to come back with his iron. So before we go into iron overload, question here, what's the significance of it being too low? If you're, yeah, referencing the ferritin, it's not like, that just means they have a more severe degree of iron deficiency. Because